Okay, chapter 10 is on documentation principles and procedures. So everywhere you work, they're going to make you document. Some places still have electronic or still have paper records. Some places have electronic medical records. Some places chart on little phones or iPads. So everywhere you work, you'll get an orientation about your expectation for charting. Getting information from our patients, the sources of patient information, and the care plan is an important part of knowing how to take care of each individual person. Residents are the main source of information. If you need to know something about somebody, ask them. Ask them what they'd like to prefer to be called. Ask them about their history. Ask them about what medications they take. Ask them about what questions you have. Ask the resident. If they have dementia, they may tell you some things, they may not, but you can still ask the resident for their input. The resident's chart is an important part of information. It's the main communication tool that's used between the interdisciplinary team, and this is a legal document. We talked about medical records where the residents cannot just get their chart and read it. They have to go through medical records because of HIPAA policies and get copies of their chart legally. Also, protected health information. Make sure you're not sharing information with people who don't need the information or who aren't directly taking care of that resident. Some places you work, the residents will have on wristbands. When you're identifying a resident, you need to identify them by two identifiers, their name and their date of birth, their name and their social security number, their name and their picture on their chart. If they don't have a wristband, they have a picture on their chart. There are door cards that are hanging on the door frames of every door that give us information about the patients. If they have a falling star, that means they are high risk for fall. If they have oxygen signs, they're wearing oxygen. All of those are giving us information about the patient. If they have an isolation sign on the door, that means they're on some sort of isolation because they have a known infection. Other people can give us information. We need to make sure we observe HIPAA policies. But people like family and friends and visitors and staff, if we figure out a code that the person needs and the patient has family members that call in over the phone, we need to be asking for that code every time before we get information to the family. But we can also ask family members the patient's routine, what they like, what they dislike, how they did things at home. Our policies and procedure manuals also give us a lot of information about how we're going to care for our patients. But the biggest document that tells us how to care for patients as an individual is their care plan. Okay. What is the difference between objective and subjective information? Your objective information is the facts. It's what you hear, what you see, what you touch. Subjective information is going to be a guess or a hunch. And it's going to be subjective is what the resident tells you a symptom that they may be having. Your medical records. Stamped with the resident's name on each page. They have many sections in the medical records. And the admission demographics we talked about. The nurse is going to come in and ask them some information about their history or their medical background and their allergies. All of the admission demographics is part of the nursing flow sheet. But the CNA is in charge of making sure that you're doing the inventory sheet part of that, making sure you're writing down what the residents bring in with them as far as their clothing, their adaptive equipment, their walker, their wheelchair, their glasses, their hearing aids. The nurse is going to do a physical exam. The doctor is going to write orders and progress notes and order labs, and lab results are going to be on the chart, and x-ray results are going to be on the chart. Their IV therapy, recording their intake and output. It is the CNA's responsibility to write on the I&O sheets. You're documenting their intake and their output. We're going to talk about that in another chapter when we talk about nutrition and output. Your admission sheet, information collected from the resident when they're admitted to long-term care. Your health history is on there. And your graphic ADL flow sheet is the flow sheet that CNAs are responsible for charting on. It's your CNA assessment sheet or the graphic flow sheet where you're going to chart all of your ADLs. You're charting how the person ate, how the person ambulated, how the person dressed, how the person moved around or transferred from the bed to the wheelchair, what adaptive equipment they need and how you're using that. 2-person assist, 1-person assist. You're also going to put your vital signs on this ADL flow sheet. So this is commonly done by the CNA. The admission inventory sheet and the ADL flow sheets are the two charts that the CNAs are going to be charting on in the medical record. So this is just an example of an ADL flow sheet where we have vital signs, and then they also have on their information for the IV medicines and the tube feedings of the enteral nutrition that the nurses are going to do. And then a place for the output, the urine and the stool and the emesis or vomit. And any drainage from any wounds. We'll talk about that in the wound chapter. Your activities of daily living flow sheet. This is another example where they will tell you how you need to chart, what you need to chart when you're in orientation. On this one, you're charting their oral care. Do they have their own teeth? Do they have dentures? Are they independent at doing their own oral care or oral hygiene? Do they need setup or do they need assistance with the CNA? Dressing, how they dress themselves, independently, with setup, with assist, or with total care. Grooming themselves, are they able to wash their face and their hands? Are they able to give themselves a shower? Are they able to comb their hair? Can they trim their nails? Lotions to their arms and legs. Shaving the men, shaving the women also too. Usually women only get shaved twice a week. Men, maybe you need to shave them every day. But if you shave them, it goes on the flow sheet. How their intake and output with their meals, and then when their vital signs are due and how often they're weighed. We need to put their bowel movements. Then sometimes they ask you to describe the bowel movement. Was it large? Was it medium? Was it small? Were they incontinent? Incontinent means they are not able to hold their bowels. They're basically just going without knowing they're going. They can't wait to go to the restroom. Bladder elimination, how they're urinating, independently, incontinent, or with a Foley catheter. We're going to learn all about that in the elimination chapter. Your weight-bearing status, toe touch, as tolerated, partial, full weight-bearing, no weight-bearing. It all depends on the physician's orders or the doctor's orders about how they can weight bear or how they can, how much weight they're allowed to put on their own legs. Transfer status, do they need a mechanical lift? Are they able to stand by themselves with one person or two-person assist? Their activity, are they able to ambulate? Do they need a jerry chair? Or they need to be turned every 2 hours? Do they need a wheelchair? And then always charting their safety. If they're sitting up in a wheelchair, do they need a lap tray? Or do they need a jerry chair? Do they need a bed alarm or a chair alarm? Or any kind of safety belts or seat belts that they need for safety? Call bell is within reach on some of them, but they want to make sure that you check that they have their call bell. Feeding status, are they independent? Do they need setup? Does the staff need to feed them? Do they have swallowing precautions? We're going to talk about that in the nutrition chapter. Do they need thickened liquids? So all of this comes from their care plan. It's very important for CNAs to let us know if these things change so that we can update their care plans. But it's also important for you to document daily on your ADL flow sheet how the patients do these things. This is the CNA's responsibility. Okay. This is just another one, functional status, nourishment, intake, and output. It's all there for us to see just on a graphic ADL flow sheet how the resident is doing for the day. Okay. How they communicate. Do they need to have verbal communication, written communication? Do they need a board, a communication board? Do they need a translator or interpreter? Things like that. This is a bath skin assessment sheet that they use. Anytime you're in the shower and you see something wrong with their skin, you don't leave them in the shower alone. You finish up what you're doing, you document it on a bath shower flow sheet, and then you let the nurse know, and the nurse can come back and look at them at a later time. Okay. Sometimes if you notice they need their toenails cut or their fingernails cut, or if they have a rash on them, their eyes are red or draining, their skin has skin tears on it, just make sure you document it on some kind of flow sheet to give to the nurse. Your progress notes. Some places you work will ask you to write a progress note only if something happens or if there's a change in the person. You only write pertinent negative information or things that have happened that are a difference for the patient. But some places don't have progress notes at all for you to write. But it is a written description of the care that you gave and the resident's response to that care. So information about special treatments, special medications, or what the nurses write about. Doctors write progress notes every day about seeing the patients. We write progress notes about the teaching and the education and the counseling that we gave to the patients. Basically, if it wasn't documented, it wasn't done. So if we teach them anything, we need to write it down. Every member of the team charts progress notes in black ink. You don't skip lines. You date and time your entry. You sign your title and your name and your title to it. So you don't mess with anybody else's charting, and you don't write all over the place. You use the next line, date it, time it, write your objective information, be brief and concise, and at the end of it, put your name and then comma CNA for your title. This is an example of a flow sheet, like nurses' notes, where you're going to be writing progress notes, where they have the date, the time, and then the note. But there are no skipped lines, and any lines that are empty have a single line drawn through them, so nobody can go in and fill in any information. It's a chronological order of what is going on for that person. In a little bit, we'll talk about what happens if you make an error in the medical record. You just draw a single line through it. You don't scribble through it so that it looks like you're trying to cover something up. Okay. We learned about OSHA in the last chapter. We're going to learn about OBRA in this chapter. The Omnibus Budget Reconciliation Act of 1987 is the Nursing Home Reform Act. It is the government's laws. The federal government made laws that they named OBRA that protects residents' rights. OSHA protects employee rights, and OBRA protects residents' rights. So residents have the right to have staff that are competent. They also have the right to have evaluations of these staff members. So OBRA comes and inspects and does a survey once a year that you will be a part of. The surveyors may ask you questions, and you may have to answer about your facility's policies, or what is expected of you, or what your duties are. So make sure you know your facility's policies and procedures. It requires every resident to have a resident assessment instrument. This is a questionnaire. Now, CNAs don't have to fill these questionnaires out, but you are very important in making sure that these questionnaires are providing good quality of care, and that when the residents are asked certain questions, they can say yes or no to them. So in the back of your book, starting on page 148, this resident interview and resident observation. It's just a few pages of what the surveyors ask the residents when they come in and do their surveys. They usually pick residents that have a good cognitive status, that can interact with them, that can answer their questions appropriately, but they pick who they want to talk to. They ask the residents about choices. They want to know, if they're given a choice, are you able to participate in making decisions regarding your own food or your own food preferences? Is this acceptable to you? Do you participate in choosing your own bedtime? Is this acceptable to you? Do you participate in choosing when you get up in the morning? Is this acceptable to you? Do you choose your dressing and your bathing schedule? They also look at their dignity. Do you feel like the staff treats you with respect and dignity? So all of these survey questions are answered by the residents according to how they're being treated on a daily basis. The resident assessment instrument gives us a template to go by to ask the residents these questions so that we know what their preferences are, how they like to be taken care of, and then we can develop their care plan. Okay? It gives us information about how they transfer, how they eat, how they participate in activities. So just make sure that you are always offering choices, always offering food, hydration, and safety. This resident assessment tool is completed once a year, but anytime there are any changes in their health status, we update this care plan. Okay, we have a care conference with families, with employees. Sometimes you'll be asked to come into a care conference. And you, as their primary caregiver, the person who's with them 80% of their day, you know certain things about those people that we need to ask you to have input into their care plans. Only the nurses are charting on these specific care plans, but your input is very important in order for us to make these care plans effective and individualized. The most important assessment for every resident is their RAI. It has lots of parts to it. It's like 33, 36 pages long. But the nurses are doing all of those to help develop our care plan, to make sure our care plan is being implemented, to evaluate outcomes, to make sure we're giving the patients the best quality of care that they deserve. But if you do see something that is wrong on their care plan or that may have changed over time, maybe they used to be able to get up by themselves. Now they're using 2 people assist to get up to get out. Maybe they need a wheelchair now where they didn't need a wheelchair before, but you've been using a wheelchair, you've been using a lift to get them out of the bed. The acuity of the patient's statuses, how much help they need, depends on how much staff we can have. So you need to let us keep these care plans up to date so that we know we need more help or we need more staff. The minimum data set, like I said, this is usually done by nurses, the MDS coordinators. They're always charting on things, but just regular graphic information, and then all of these sections about their hearing, their speech, their vision, their mood, their behavior, their diagnoses, their functional status, how they void, how they stool, about their skin, about their dentures, about their vision. All of these things are important to be individualized. Quality indicators, when the surveyors come, they're looking at reports to see how many patients fell, how many patients have pressure ulcers, how many patients have fractures, how many patients have urinary tract infections. All of those quality indicators let us know or give us clues into the care that these people are receiving. So you as a CNA are providing this quality care, then the numbers should look good. They do look at the number of restraints. The facility that we work at is a no restraint facility, so you won't be putting anyone in restraints, but we're going to learn how to do restraints in case. The number of fecal impactions, how many people are constipated and haven't had a bowel movement in 3 days and are impacted and nobody knows. Number of drugs, psychotropic drugs. So these are the drugs that we're giving them to calm them, maybe sometimes to sedate them, to keep them. They want to know how many people are on these drugs that are making them drowsy. So the state has to list the survey when they arrive, and it's public knowledge. We already talked about the surveys being available in the front lobby. But our care plan is important for you. It lists the resident's needs and goals, as well as the actions and approaches to care that the facility needs to help this resident meet their goals. So on your national exam, it's going to ask you, what is the written plan that tells us about the needs and the goals of each individual person? It is their care plan. And you need to look at their care plan before you do anything to them. We're going to go into the shower room. You see parts of their care plan hanging on the wall that tells you what shower chair they use. Can they get in the shower independently? Are they going to get in the shower in a shower chair? Can they even get in the shower at all, or do they need a bed bath? This care plan is always changing. It's kept at the nurse's station in a separate binder. Sometimes it's in the resident's chart. We have parts of the care plan on the CNA activity sheet for the day. That's why it's protected health information, and you need to make sure you shred that. You don't take it home with you. Your observations are important, but your assignment sheet has a list of things on there that come from the care plan. And if you notice that that assignment sheet does not match how you care for your patient, you need to let us know. It is not part of the resident chart. Those CNA assignment sheets have multiple patients on them, and they do not go in a chart. They're just there for the CNAs to help you get a brief synopsis of their care plan so you can take care of them appropriately. This is just an example of a goal and some approaches and some target dates that we need to meet. We want the residents, when the problem or need was assessed, that maybe the resident wasn't going to activities. So the goal and the target was to help them maintain a current activity participation by the next review. And then the approach is to offer them praise initiate conversation with them, engage them in group activities, and assist them with planning their leisure time activities. So that's just, there's always a problem, there's always some goals, and then some interventions on how we're going to meet their needs. This is an example of a CNA assignment sheet. On here, each CNA, depending on the acuity level of the patients and your workload, some places you work, you're going to get 5 patients, some places is 15 patients. Depends on where you work and how sick your patients are or how much help they're going to need. So this is where you're going to need to know your medical abbreviations that we talked about. Wheelchair, WC, NPO, nothing by mouth, ad lib, as needed, or as desired, PRN, when necessary, HOH, hard of hearing. All of those are going to be in the charts, and they're also going to be on these CNA assignment sheets, so that if you don't know what an abbreviation is, ask so that we can let you know what it means. Reporting information. When you have routine reporting, it is just general information. You come in and we tell you by 10 o'clock, please have all the vital signs on the charts. If it is a normal vital sign, you just write it down on the chart or on the flow sheet or where it needs to be. You're including objective, subjective information. You give end of shift report to the next CNA that's coming on. When resident care is being changed over. You only give the information to the caregiver on the next shift. Not everybody in the whole building needs to know about patients if they are not directly taking care of them. Immediate or stat reporting is reporting of a dangerous situation if a vital sign is abnormal, if someone's complaining of pain, if someone had a fall or an incident report. That is a stat emergency. Okay? Any abrupt changes in their health status, they become unconscious, they become lethargic and can't talk anymore, you need to let us know. Okay? If their blood pressure is too high, if their temperature is too high, that is a stat or immediate reporting. Don't just write it on the flow sheet and say, well, I wrote it down, somebody should have looked at it. By your certain time reporting is the one where by 10 o'clock we're going to have the vital signs on the chart so the nurses can give the blood pressure medicines. By a certain time reporting, when meals are finished, after the meals are done, we expect you to record the percentage of output, the percent and the milliliters of how many cc's or milliliters of fluid that they drank. 1 ounce is equal to 30 milliliters. So we don't chart in ounces, we chart in milliliters. We're going to go over that in our nutrition chapter. And then, of course, incident reporting. Incident reporting is done when there is any major injury or accident. It doesn't matter who it happened to, you're going to write an incident report. If it happened to a staff member, if it happened to a patient, if it happened to a family member or any other visitor, if an incident or accident happened, we have to have an accident report. Make sure the information is objective, only put on there what you know the facts are.
As a nursing assistant, you will spend much of your time with the residents in your care. This daily interaction with residents gives you the unique opportunity to notice changes in the resident, which others might not notice. In the first segment of this video, we will discuss observation and reporting guidelines. These guidelines will help you note signs and symptoms of illness so you can report them to the nurse. Signs and symptoms of illness should be reported to the nurse immediately. These include chest pain, shortness of breath, difficulty breathing, weakness or dizziness, headache, pain, nausea or vomiting, diarrhea, cough, cyanosis or changes in color to blue or gray. In dark-skinned residents, this is noted in the mucous membranes, lips, and nail beds. Change in mental status, excessive thirst, lethargy or excessive drowsiness, unusual drainage from a wound or body cavity, or changes in vital signs. Now we'll look at some of the specific problems you may encounter and the observations you'll need to report. Consider this scenario. You enter the resident's room to find her lying in bed, appearing ill. You ask how she feels. She reports she doesn't feel well and complains of cold. You touch her skin to find it hot to touch. What signs and symptoms do you recognize? What might be indicated here? Notice that the resident's skin is flushed and she complains of being cold. Her shivering indicates that she is having chills, and the nursing assistant indicates that she feels hot to touch. The most likely cause is infection. Other signs of infection to look for include sweating or perspiration, skin that looks flushed, red, gray, or blue, or that feels unusually hot or cold. There may be inflammation of skin as evidenced by redness, edema, heat, or pain. And you may see drainage from or body cavities or discharge of mucus or pus. Consider this next scenario. You are walking by a resident when you hear him call for help. You rush into the resident's room to find him touching his chest, complaining of severe chest pain. It's obvious that the resident is complaining of chest pain, which must be reported to the nurse immediately. What types of pain should be reported? Since we want the resident's care to be comfortable, we will want to report any pain to the nurse as soon as possible. Pain is our body's way of letting us know there is a problem and should never be ignored. Certain types of pain should be reported immediately, including any chest pain, any pain that radiates to another area of the body, pain upon movement, and pain during urination or while having a bowel movement. Monitor confused patients for grimacing and body language suggesting pain. Always report your findings to the nurse immediately.
Okay, we're going to talk about observing and reporting in another chapter as well, but just make sure that you know what things are abnormal that you need to report. If they say something is pink, like your nails are pink or your lips are pink, that is a normal finding. So your lips and your nail beds should be pink. But if they are blue or cyanotic or purple or red, then they need to be reported. If anybody complains of chest pain, that is a stat immediate reporting. If they complain of other things, yes, we would report that as well, but if the options give you a bunch of different things and they say chest pain is the number one, has to be reported immediately. Chest pain and a headache that they say is like a thunderclap headache or the worst headache of their life, they could be having a stroke. But you are going to tell us if they have a change in appetite. You're going to tell us if the diabetes people don't eat. You're going to tell us if they have joint pain. You're going to tell us if they're incontinent. If they didn't previously, if they're not normally incontinent and now suddenly all day today they're incontinent. Yes, we need to know that, but the biggest thing is that we need to know they're having chest pain. Okay? And then also as far as their vital signs or if they just look funny to you, if they're breathing difficulties, if they're having rapid respirations or shallow breaths, shallow rapid breaths need to be reported immediately. Or stat. Your role in documentation, again, we've already talked about the residents' names being on the chart. It has to be written on both sides of the page, just like you're filling out every form here in class. We put your name on the front and the back. You're writing in permanent black ink. You're not supposed to write in pencil. You're not supposed to write in fancy colors. You can't write in like felt tip markers that will smear if they get wet. Write each entry so that it's easy to read. Pay attention to your penmanship and handwriting. A lot of places have electronic charting now, so you can just type it in or press a button or press a little icon. Our charting is continuous. We're not leaving spaces or skipping lines. We're documenting only our own actions and observations, and you can only document after you've completed the task. If you know you're supposed to be helping this person with a shower Monday, Wednesday, Friday, and it's Wednesday, you can't just document that you gave them a shower because you may go in there and they decline their shower. So even if they decline, you document that they declined. but you don't document that you gave them a shower. So make sure you don't document until after the task is completed. You have to wash your hands before you touch their chart and document. When we're doing our national skills testing and we're doing vital signs, make sure you say, wash my hands before you touch that chart and document on it. Don't tamper with other people's charting. If you make an error, you just draw a single line through it and correct it. So this is what it would look like if you have an error. Sometimes they want you to write the word error and put your initials, and then just keep on going on the rest of the lines. So don't scribble anything out so that it can't be read, so it looks like we're trying to cover something up. We're going to learn about our standard medical abbreviations, some standard medical terminology. You can use medical terminology and medical abbreviations when you are charting and documenting. It helps save time. It lets people know what we're talking about. We know this language. Okay, in the back of your book, there are some medical terminology pages and some standard abbreviation pages. You cannot write like you're texting. You can't put texting in a medical record. You have to use the standard approved medical abbreviation. Write down the date and time every time you write an entry. If you're doing it on a computer, it automatically timestamps it for you. But if you are writing something in a chart, you start your entry with a date and time, put what you need to put for your objective information, and then sign it with your name and title at the end. Okay. Use the resident's exact words and quotation marks when possible. That's part of the subjective information. They said, quote, my stomach is hurting. Put it in quotes. Okay. Chart any changes in the normal or changes in the resident's behavior. If you've informed the nurse and you need to chart something down, you put the date and time and the name of the nurse that you told. You're not supposed to be omitting information or leaving anything out, but you also don't need to be putting too much information in their charts. You record safety measures. If there's a place to check a box that says they have their call bell within reach, or their chair alarm is on, or their bed alarm was checked, or their wander guard. Some people wear a bracelet or an anklet, which is a wander guard on them. It's a device that will, when they get close to a door, it activates the lock on the door and locks the door so they can't get out of the facility. But if they stand at that door long enough, the door is going to be beeping. And because of fire safety regulations, after a few seconds, the door will unlock. Okay, so make sure if you hear that beeping sound, we're going towards that door, the open doors, to see where our wandering patients are. All right. Be accurate, be concise, be factual. Do not record your own judgments. Only put the facts. Some of these charts are going to have to be read out in courts. Systems. Don't write anything in a chart that you would be embarrassed to read out loud in front of a court, in case you're subpoenaed to court one day if someone tries to sue. Okay. Any questions about charting?